A very good afternoon to all of you. Myself, Dr. Prateek Garg. So today's topic in ENT is BERA. What do you mean by BERA? BERA is Brain Evoked Response Audiometry. So BERA is basically Brain Evoked Response Audiometry. That means it is an audiological test which detects the pathway starting from 8th cranial nerve at the level of till, or we can say till, brainstem. So it is a test which access the auditory pathway from origin of 8th cranial nerve, that is vestibulocochlear nerve, till brainstem. And how we do this test? So see, in the patient we just provide the sound energy in form of click sound or tone burst. So we are producing the click sound or tone burst sound in the patient, and then we are recording the response which starting from 8th cranial nerve till the level of brainstem. So we just record the response till the level of brainstem, and according to that we think or we can diagnose certain pathologies. So it is a non-invasive test. In BERA we don't do any procedure, any invasive test. So it is a non-invasive test. Now one more important thing, the best time for BERA. See, the best time for BERA is in uterus 34 weeks. That means it is a test which can be conducted in uterus. Baby is not born, still we can conduct the test BERA, and the best time is considered of 34 week of gestation. So very useful test. And with the help of BERA, we can think about the retrocochlear lesion, whether the pathology is at the level of the 8th nerve or at the level of lateral lemniscus or at the level of the brainstem. So you can easily identify at which level the pathology is there. So BERA is basically best for. So firstly, to detect the hearing loss in infant, we know pure tone audiometry that can't be very helpful in infants because that is a subjective test. Pure tone audiometry, patient need to tell the examiner that at this particular frequency is hearing the sound or not. So in infants, practically pure tone audiometry can't be done. So BERA is very useful for the infants to detect the hearing loss. Then comes malingering, patient who are lying. Some females, young female, they just pretend that they have some hearing loss. So malingering can be assessed by means of BERA. Then screening of neonates in ICU. Some babies are born with some sort of other pathologies and they are into the ICU. So you can also use BERA for the screening purpose, whether they are having good hearing or not. And plus lastly, the retrocochlear lesion. Now basically BERA, how we do? See, we have already discussed, we are giving the click or tone burst sound to the patient by means of the instrument or by means of some earphone. So in that, so according to that response, some of the waves or some of the electric impulses are being generated in the 8th cranial nerve till the level of brainstem, and we record that response. So mainly in BERA there are 7 waveforms are being formed. Look at the diagram, wave 1, 2, 3, 4, 5, 6 and 7, out of which wave 5 is considered most important or very useful for any pathology detection. So what are the levels at which these waves are generated? Wave 1, it starts from distal part of 8th cranial nerve, that is the origin of the auditory nerve from the cochlea. So wave 1 is from the level of from the auditory nerve which is very proximal to the cochlea. According to the brain, we can say it is a distal part of the cranial nerve which is lying towards the ear. Wave 2 is generated from proximal part of the 8th cranial nerve which is going towards brainstem. Wave 3 is from the cochlear nucleus. Wave 4 from superior olivary complex, and wave 5 is from lateral lemniscus. Very important, this has been asked in the exam. See, we used to remember the auditory pathway by means of SLIM, S-L-I-M. So what do you mean by SLIM? See, the cochlear nerve, vestibulocochlear nerve start at the level of the cochlea, then it progress towards the brainstem, then they relay in the cochlear nucleus from where the wave 3 is generated. Then from there it ascend into the superior olivary complex. L stand for lateral lemniscus, I stand for inferior colliculus, and M stand for medial geniculate body. So that's how we remember SLIM. So wave 3 is from the cochlear nucleus, then wave 4 is from the superior olivary complex, wave 5 is from the lateral lemniscus, and wave 6 and 7, these are from the inferior colliculus. So out of which wave 5 is considered very pathognomonic. Now let's look at the table which is showing the results how to differentiate between the cochlear and retrocochlear lesion by means of various audiological tests. So let's think about pure tone audiometry, which is PTA. Okay, so in a normal person, pure tone audiometry will show normal, whereas if the patient is having cochlear lesion or retrocochlear, in both the pure tone audiometry will show sensory neural hearing loss. Then comes speech discrimination score. Usually in a normal person, it is 90 to 100%. That means patient can identify or discriminate between various sentences or speech, and the score is around 90 to 100%. Suppose it's a cochlear lesion, then it will be little diminished, below 90%, not very much hampered. But in retrocochlear lesion, that is a lesion involving the 8th cranial nerve or the brain, like the acoustic neuroma, speech discrimination score will be very poor. So speech discrimination score basically tell about retrocochlear lesion. Then third investigation is rollover phenomenon. Usually in a normal person it is absent. It is also absent in cochlear lesion but present in retrocochlear lesion. So rollover phenomenon is further diagnostic of any retrocochlear lesion. Then comes recruitment. We know we have learned this term recruitment in the Meniere's disease, where after a certain decibel or a certain threshold of the sound energy, the patient is perceiving the sound more louder. Okay, so recruitment test normally it is absent, but in cochlear lesion like the Meniere's disease, which is known as endolymphatic hydrops, or any other cochlear lesion, recruitment test will be positive, and it will be absent or negative in retrocochlear lesion. So recruitment test is pathognomic of cochlear lesion if it is positive. Then other investigation is CC score, short increment sensitivity index. Again, CC score, it is pathognomic of cochlear lesion, where the CC score will be greater than 70%, whereas in a normal person or in a retrocochlear lesion it will be around 0 to 15 to 20%. So recruitment test and CC score, they both are representing or telling us about the cochlear lesion, whereas the speech discrimination score or the rollover phenomenon, they are more diagnostic of the retrocochlear lesion. Then threshold tone decay test. Again, this tone decay test, it tells about the nerve fatigue also. Okay, so this tone decay test, it is above 25 decibel in a retrocochlear lesion, whereas in the normal person or cochlear lesion it is less than 25 decibel. Then comes stapedial reflex. Stapedial reflex is an preservative or protective reflex which is being elicited by 7th cranial nerve, and the sensory supply for stapedial reflex is 8th cranial nerve. So stapedial reflex will be present in a normal person plus a cochlear lesion person. But suppose if there is a defect in the 8th nerve or 7th nerve, then this reflex will be absent. So stapedial reflex will be absent in patient like the acoustic neuroma or any patient with retrocochlear lesion. Then stapedial reflex decay. Again, this is abnormal in retrocochlear lesion, whereas it is normal in normal person or the cochlear lesion person. Lastly, BERA, that is brainstem evoked response audiometry, general in cochlear lesion, or a patient with a normal ear, there will be normal interval between the wave 1 and wave 5. We record the time period between wave 1 and wave 5, so it will be normal interval. And suppose the patient is having retrocochlear lesion, some sort of brainstem tumor, some sort of acoustic neuroma, some sort of trauma at the level of internal auditory canal, then this wave 5 will be delayed, and by the level of wave 1, 2, 3, 4, and then we know their origin, that wave 3 is originating from the cochlear nucleus, wave 4 is originating from superior olivary complex, so we can detect the pathology lies at this level. Lastly, test for malingering. We all know, we have studied now, the BERA can be useful in detecting malingering patient who are telling lie about their hearing status. So what are the other tests? One is the Stenger test, important for the exam, has been asked multiple times. So Stenger test, then comes stapedial reflex. Suppose patient is telling lies, still the reflex will be present if he or she doesn't have any pathology and he or she is denying the fact that whether he or she can hear properly. So we can elicit the stapedial reflex, so it detects the nerve pathway, nerve conduction, so that will be present if patient is malingering. Then comes speech audiometry, and lastly is the BERA.